Thank you, Amelia, for your kind introduction. Thank you, the audience, for being here, and thank you to the committee for inviting me for this presentation. So the title is very unspecific. It's about apheresis. It's about the diseases that, for which we do apheresis, and also what are the challenges that we have to obtain evidence to support this treatment. So I have nothing to disclose. And I think this is a very first nice slide to represent what I'm going to talk about. So parachutes reduce the risk of injury related to gravitational fall, but their efficacy has not been proved by randomized controlled trials. And when I see this, actually I see apheresis. So during the first 10 minutes of the presentation, I will talk about the apheresis principles. I'm not sure exactly how much, I would like everybody to have a basic understanding of apheresis. I will go through the American Society for Apheresis guidelines that provide recommendations about treatment. I will go through two disease examples. One is going to be ABO incompatible transplantation, and the other one leukocyte apheresis. And even though they are not related, I will show you how they are actually related. And then challenges and opportunities looking into the future. So first, starting with definition. So apheresis means to remove. So we can remove plasma, and that is called plasmapheresis, or we can remove cells, which is cytopheresis, which is different from phoresis, which phoresis is transmission, such as in electrophoresis. We don't do that to the patient. We don't do any electrical transmission. So sometimes we see plasmapheresis in the chart, and that's a misspelling, or that's not what we do to our dear patients. So the concept of apheresis is a historical concept in terms of removing something that is actually pathologic, and that started hundreds of years ago with the bleeding, or when the patients were treated actually by bleedings. But it wasn't until 1956 when the first manual apheresis procedure was performed on these patients that had Waldenstrom's hyperviscosity. So for those of you that are not familiar with this disease, there is a high concentration of IgM, which is an antibody, and that can produce an increased viscosity on the blood. And because of that, the patient can have neurologic symptoms and don't feel very well. So the treatment for that is to try to remove those immunoglobulins. So for these patients in 1956, what it was done, they introduce a needle, they collect 1 unit of blood, they spin the blood, remove the plasma with the pathogenic IgM, and then return the red blood cells into circulation. And that was done throughout 15 days, and the patient recovered. So this is exactly what we do when we are doing apheresis procedures in our patients. The only difference is that now we have automated mechanisms, and we can use machines to perform that. So how it works. So these are the two machines that are currently in use. There are other machines, but these are the two most frequently used. This is a Cobb Spectra, and this is a Cobb Optia. So this is a machine that has been running since 70s or 80s. It's an excellent machine, and it was time to replace it. So about 5 years ago, the Optia was introduced. Not many people is happy with the change because this machine is so very well known and everybody's so used to it, but this is what we are changing. So this Cobb Spectra has, and this one too, has a centrifuge inside. So the blood is removed, the patient is connected to the machine, such as in a dialysis instruments, very similar procedure. And then the blood is collected into this centrifuge. By centrifugation, it is possible to get a separation by a specific gravity, and we can separate the different components of the blood. So we can separate red blood cells from the buffy coat from the plasma. And then we can decide exactly what is that we want to collect, depending on the disease of the patient. So here you have the specific gravity of the different components of the plasma, and this is of the blood, and this is exactly how it looks in the interface, in the centrifuge. So the red blood cells will go to the bottom. The polymorphonuclear cells are going to be very close to the red blood cells. Blasts, monocytes, and lymphocytes are going to be close together. Platelets on the top, and then plasma. So you can specifically ask the machine to collect either plasma or platelets or different cells components. So because we have this ability to separate blood components and to collect whatever we want, we can do not only therapeutic procedures, but also donor apheresis. So we can connect to this machine healthy donors for transfusion purposes. So we can collect plasma, and that's what we call plasmapheresis. And basically, we would like to do this to donors that are AB type. And the reason for that is that AB plasma doesn't have any antibodies on it. So that's the universal donor. We can also collect cells, such as red blood cells, platelets, granulocytes, and also hematopoietic progenitor cells. So these cells are collected for transfusion purposes. So we can, the most common way to do at this time bone marrow transplant is by collecting peripheral stem cells through this machine. So the focus of this talk is about therapeutic apheresis. So when we are talking about therapeutic apheresis and we remove plasma, we call it plasma exchange, because when we remove the plasma, we are going to replace whatever we are removing, or the plasma that we are removing. So the reason we may want to remove plasma is because the plasma has pathologic substances, such as, for instance, antibodies or paraproteins or inflammatory mediators, drug or toxins. We may also want to remove cells, which is going to be called cytopheresis, to remove pathological cells, such as we can do a red cell exchange for patients with sickle cell disease to remove cells with abnormal hemoglobin, babesia or malaria with patients that have very, very severe disease. We can also do leukodepletion, and this is important for patients with acute leukemias and very high white blood cell count that present with symptoms of leukostasis. And we can also remove platelets for patients with essential thrombocytosis that are not responding to treatment. So since I'm talking about apheresis, I just wanted to give you an introduction of other types of apheresis procedures. I'm not going to expand on this, but just to give you a brief overview. So LDL apheresis, I would like to ask the audience, how many of you have heard about LDL apheresis? All right, so this is excellent, just 5 of you. So this is a procedure that we perform here at the university, actually, together with Harborview. The machine is sitting at Harborview, but covers patients at the university and Harborview Medical Center. So this LDL apheresis procedure, what it does is that it removes LDL, actually. And the mechanism of separation is a little bit different. So again, we have a patient that we remove blood from the patient. We don't use a centrifuge to separate the different components of the blood, but actually we use a plasma filter or a filter that separates the plasma from the red blood cells. And this would be very similar to dialysis. When the plasma is separated, it goes through a plasma pump that then runs the plasma against some columns that can absorb the LDL. And then the plasma and the rest of the components are returned to the patient. So the other apheresis procedure that I wanted to mention is photopheresis. This is a very, how many of you have heard about photopheresis? All right, so 7 of you, so that's a little bit more than LDL apheresis. So photopheresis is I found it very fascinating and interesting what we do with this machine. So what we do is also we collect blood, we separate through centrifugation, but we take the buffy coat with the white blood cells. We introduce soralen, that is a component that intercalates into the DNA, and then just to the white blood cells. And then the white blood cells are illuminated with UV light. So the soralen becomes activated and damages the DNA. And then the buffy coat is reintroduced to the patient with these damaged white blood cells. So these damaged white blood cells, it is thought that they can produce an immunomodulated response into the host. So this treatment is usually used for cutaneous T-cell lymphoma and graft-versus-host disease, but it's being increasingly used in patients with cardiac and lung transplant rejection, cellular rejection, not antibody-mediated rejection. And the role of this mechanism for autoimmune diseases is still not known, but it's something that is under research at this time. All right. Okay, so going back to our apheresis, therapeutic apheresis procedures. So there is what I like to call apheresis prescription. So when we are talking about, or we are considering a patient for apheresis treatment, we need to think that the patient needs a vascular access. We are going to use an anticoagulant during the procedure. That it could be either citrate or a combination of heparin and citrate. We are going to choose what the amount of volume that we are going to process, the replacement fluid that we are going to use, and the treatment plan. And all these varies based on the indication. So apheresis is usually very well tolerated. So sometimes we think, can we benefit this patient from apheresis or not? Why we would consider to do an apheresis procedure in a patient? So for the most part, we use the McLeod criteria, which is expressed here. So if we understand a little bit of the pathogenesis of the disease, is it antibody-mediated rejection? Is there something that we can identify is in the plasma that we can remove, or in the red blood cells that we can remove? And if we remove it, actually, the patient is going to have an improvement, or it's going to be perkier, as it says here. So we may consider to do an apheresis procedure on these patients. So this is a Russian ad on the internet about promoting plasmapheresis and how well and how happy people get after apheresis. I never saw one of our patients jumping like this. I wish they were, but what I can say is that sometimes apheresis can produce significant improvement only with one treatment. And as it says here, unfortunately, long time, this procedure was not a widespread occurrence due to its high cost, equipment, and the process complexity, lack of cheap and effective disposable systems. So I'm very unfortunate. So once we make the decision that the patient may benefit to get a treatment, the other thing is that the American Society for Apheresis has developed these fact sheets which help us with the disease understanding and also to decide whether we can do apheresis or not in this particular patient. So these fact sheets have lots of information about specific diseases, such as the frequency of the disease, the procedure, and what is the evidence to do the treatment, the description of the disease, what is the current management, why we would do apheresis on this, and the technical notes. So for the most part, every time we receive a request for apheresis, there is already a fact sheet describing this. If there is not a fact sheet, we would use the McLeod criteria to say, can we really benefit this patient by removing some particular component of the blood? So one of the things that I like the most about apheresis is that we get to interact with lots of different clinical teams. So all these 78 fact sheets or current indications for apheresis include hematological, nephrologic indications. We work with surgery and transplant, neurology, rheumatology, and internal medicine. So the variety of the diseases that we can treat is very broad. So the ASFA guidelines have developed different, or have categorized the diseases as from 1 to 4, being category type 1, a first-line therapy, category type 2, second-line therapy, 3, it means that the role of apheresis hasn't been determined, and 4, it means that it is ineffective or harmful and we shouldn't attempt to do apheresis. There are a few of these diseases actually that it's been shown that apheresis is not effective. So in addition to the category, ASFA has included the grade system to recommend based on the strength of the evidence. So grade 1 means a very strong evidence, a very strong recommendation, and grade 2 means a weak recommendation. And the strength of the evidence is subdivided in A, B, and C based on the high quality, moderate quality, or low quality evidence. So the lowest evidence that you can get is the 2C, as you see here. Let's see. It's the 2C. And as you can see, most of the apheresis indications have this type of evidence at this time. So every time we do apheresis on a patient, for most indications, the evidence to support the indication, well, the evidence to support the treatment is actually very weak. So I would like to talk about two particular diseases that can represent the difficulties to get evidence on apheresis. So the number one is going to be ABO-incompatible solid organ transplantation. So what is the role of apheresis on this transplant, in this type of transplant? Well, number one, we can do desensitization, which means remove antibodies before the organ is transplanted. Number two is rejection. So after the organ has been transplanted, if there is no development of antibodies, we can remove those antibodies to protect the organ. The antibodies that we may consider to remove include HLA, ABO, angiotensin receptor, endothelial antibodies in the case of renal transplant, and other antibodies that we don't know, but we know they may exist. So just to give you an idea of what is the ABO matching process for solid organ transplant. So in the same way that we have ABO antigens on the red blood cell surface, we also have ABO antigens on the organ, in the organs, specifically on the endothelium. So the endothelium of the organs express ABO, and that's the reason the ABO it is important when considering a transplant. So for instance, if we have an O individual, it's an O donor, this O donor doesn't have any antigens on the kidney, so on its organ, so he can donate or she can donate his organ to any recipient. In turn, when this same O individual is a recipient and needs an organ, the only type of organ that this patient can receive is an O donor. So this creates some disparity in the organs available mainly for O recipients. So when surgeons and transplant teams need to decide what are the determinants for organ allocations, for kidneys, the waiting time is one of the main determinants of who should receive an organ. And the second time is how compatible that organ is to the donor. For kidneys, for liver, it's a little bit different. Livers, the medical urgency would determine who receives the organ first. And this is a current waiting list based on the ABO type. So for the most part, O patients are the ones, like 50% of the current list is mainly O patients. Again, they are in a disadvantage because the only organ that they can receive is an O, followed by A, B, and AB. And this is true for all organs, and when we look at the kidneys and liver organs as well. So what are the options to increase the donor pools to try to benefit these O recipients? Well, number one, we have the deceased donor. That's the number one option, and then the living donors as well. So the living donors only represent 50% of the kidneys at this time. And I'm proud to say that last week we performed our first living liver donor here at the transplant here at the University of Washington. So that's something that may grow in the future. And the surgeon is sitting here in the audience. So the other thing that we can do is something that is called per kidney donation. And the per kidney donation is something that is very commonly used here at the University of Washington, in which a donor is not compatible with a recipient, and this donor is paired with another donor that is not compared to a recipient, and then the organs are swapped. So that's another way we can increase donor availability for recipients that don't have a very good match. There are also desensitization protocols, again, trying to remove antibodies from these patients. And we can also combine the per kidney donation together with the desensitization to increase the donor pool. There is another strategy that we do use here at the University of Washington, which is to use non-A1 organs, and that means an A2 organ, for instance, to be recipient. And just to make it clear, an A2 is an organ that has A antigens, but in very, very low amount. So they express so little A that maybe the anti-A antibodies are actually non-significant. So this A2 could be potentially assumed to be very alike to O recipient. So what are the risks associated to incompatible transplant? Well, these organs are incompatible because the recipient have antibodies that can reject the organ. So these antibodies can bind the antigens on the allograft and can result in rejection. So the rejection can be hyperacute when we have preformed antibodies, and that's minutes to hours, and actually during the surgery, the organ can turn black and just being destroyed by the antibodies. It could be acute antibody-mediated rejection, or it could be acute cellular rejections, mainly by B cells, or chronic rejections with chronic rejections could be through antibody-mediated or cellular or both. So if ABO-incompatible organs are so dangerous, why we dare perform incompatible transplant? Why we try to attempt this? Well, the number one thing is that there is a high mortality rate in the waiting list. So we need to increase the donor pool for these patients, because we do have the ability to remove preformed antibodies with plasma exchange, and that's the desensitization protocol. There are very strong immunosuppressive strategies that we can use for these patients. And we also have the ability to remove newly formed antibodies. And also there is one mechanism, and this is an immunologic mechanism that is called accommodation, that mainly happens in the organs to try to survive this incompatible state. So going to the evidence, what is that we know about this incompatible transplant? So the number one or less incompatible will be these A2 kidneys. So A2 means that they have a very, very low expression of the antigen that can be safely transplanted into the B patients. So the B patients do have anti-A. So if we pick the patients that are B with very low anti-A titers, we would assume that this low anti-A would not affect the A2. And this is actually something that is being done. So the UNOS allocation system acknowledged this possibility, and if a recipient has very low titers, there is no need for desensitization, there is no need for post-transplant antibody follow-up. And these patients have very similar outcomes to fully compatible organs. So this is something good, and we are not doing apheresis for these patients. So what if we want to do an ABO, completely ABO incompatible transplant? If we want to do an ABO incompatible transplant, we need to look at the ABO antibody titers. The titers can be done in different ways, such as tube or gel method. The most important thing is that one institution have a very robust and consistent way to perform these antibodies. There is a lot of variability between institutions when doing titers. The titers can be done or are usually done at room temperature, that means our IgM, or it can be done through the anti-human globulin phase, which are mainly IgG. So we do care about both IgG and IgM. The therapeutic plasma exchange can be done before and after the transplant, and I will show how, followed by IVIG infusion. And the goal is to decrease the titers to a safe level that is not going to result into rejection. Usually the safe titer is less than 16 for kidneys. So this is a very common, it's one of the common or popular, at least at Johns Hopkins, desensitization for ABO incompatible transplant. So what they do is between 10 days and 1 week before the transplant, they would start with immunosuppressive medication and plasma exchange combined with IVIG, reducing the titers. And the amount of plasma exchange and IVIG depends on the level of the titers. Then the transplant is performed, and at that time, the patient receives either rituximab, which is an anti-CD20 antibody, or splenectomy in the old days, with rituximab splenectomy has been replaced. And also receives steroids and daclizumab. And after the transplant, the patient is followed with plasma exchange, trying to control the titers. Again, it is expected that the titers are going to increase after the transplant just because the antigen is being placed into this recipient. So there is going to be an immune stimuli to increase the titers. So plasma exchange needs to be done after the transplant. And if the titers are very elevated or is not responding very well, there is a chance to repeat the rituximab or to perform a splenectomy. Many times, rejection is treated with splenectomy. So with this, based on this treatment schedule, what they looked it was that for the most part, patients with very low titers only needed 2 plasma exchange treatments before the transplant, and after the transplant also about 2 treatments. But as there was a good correlation between the titers, the pre-transplant titers, together with the number of procedures they have to do. So for instance, if the agglutination if the titers were between 64 and 128, the patient would need between 4 and 6 treatments before transplant and about 4 treatments after the transplant. This is to keep the antibodies low, the titers low. And when they look at the outcomes at 1 year, 3 years, and 5 years was 93, 92, and 87% for graft survival, and very similar for patient survival. So the outcomes are very similar to the regular ABO-compatible transplant. So I need to say that there are no randomized controlled trials looking at ABO incompatibles without plasma exchange, for instance, because we know we would fail this. So what is this accommodation that I mentioned before? So after the transplant, what happened with the titers? You have an incompatible organ now. The patient already had antibodies. Why there is no rejection? Well, it is thought that there is a mechanism that undergoes in the graft, not from the donor. The donor is being immunosuppressed, but it's some changes that happen on the graft. So accommodation is different from tolerance. Tolerance is a response from the host. So tolerance is developed when the host decreases the response to the graft. Accommodation is the graft changing its structure to decrease the immune response or the damage induced by the recipient. And we know this because if you take a recipient that has an organ and now the organ is accommodated and you give another organ from the same donor, there is a very strong response. So the change has happened in the graft, not in the donor. The antibodies in the recipient retain antibody binding and complement deposition, and the hypothesis is that there is a regulatory pathway that prevents injury. So what are the postulated mechanisms? Well, changes in the epitope spreading, so changes in the endothelium in terms of the antigen expression. And also it is thought that anti-A and anti-B antibodies can bind the cognate antigen, and we know that A and B antigens can bind von Willebrand antigens, and they can induce a downregulation of the immune response. Again, these are basically postulates, so it hasn't been completely elucidated. So the main question that I wanted to ask is, so we know that in liver and kidneys this works very well. Can we do the same in livers? That was my main question. What we need to know is that ABO is not the same as HLA. So ABO are carbohydrates and HLA are polypeptides. So we know that the immune response that they can elicit is completely different. And this is critical to know because for kidneys, the HLA typing is not as critical as the ABO. Livers are not kidneys, and the reason for this is that the kidneys are very sensitive to anti-A and anti-B, but livers, they may not be as critical. Adults are not big children, and for this is because we know that when we do ABO-incompatible livers in children, they have a better outcome than when we do them in adults. And then living is not the same as deceased. And the reason for that is that we know that the preconditioning treatment when we are using a living donor is different from when we're using a deceased donor. So following the same model that I took with the kidneys, what is our experience with the A2 livers into the O patients? So we have, so there was a report in 2012 about 358 patients that were O, who received the A2. If you remember, the A2 is the one that has very, very low A, and the O patients are the ones that have anti-A. So this is a 20 years worth of data. And what they show is actually these A2 organs is exactly the same as the O organs. And these patients didn't receive apheresis or didn't receive any other different immunosuppressive medication than the compatible livers. So this paper with 358 patients, which is a very nice number, showed that maybe the anti-A titers for the A2 livers is not as critical as we think. And then when they look at in this cohort of patients, they didn't check the antibodies. So there is no mention of the titers of these antibodies. This, in 2006, there is about 10 patients that were evaluated, and we do have the titers for these patients. And what they found is that, again, this is a very small cohort of patients, only 10 patients. The high anti-A titers did not predict antibody-mediated rejection. So there were patients that have rejection with very low titers in the 128 range. And there were patients that have titers more than 6,000, 8,000 with no rejection. So maybe this rejection was not related to the titers, or this is what it suggests. What is the UW experience? Well, in the last 10 years, we have done 14 A2 livers into non-A patients. So for the most part, these were 13 O patients and 1 B patient. So we haven't done the titers on these patients because it seems that it is not relevant. Only for the last two, only in 2 patients we look at the titers, and the titers were kind of elevated in the 256 and 1,000 for both patients. And these patients, all these 14 patients except one, had a graft survival of at least 1 year. So there was one patient that did have graft failure, but it was not related to antibody-mediated rejection. So in terms of, that's the A2 experience. What is the experience in ABO incompatible liver transplant? And this is a full incompatible transplant. Well, there are only case series and case reports. There is not a lot of literature out there. We know that it is a high-risk procedure. It increases antibody-mediated rejection risk that is manifested as hepatic necrosis and intrahepatic biliary complications. There are some desensitization protocols for living donors, mainly from the Japanese experience. And there is no standard protocol for deceased donors. So again, the University of Washington have performed only 1 living donor. And for the most part, we use deceased donors. There is nothing published about deceased donor desensitization. So for the living donor, the experience from Japan have shown that when they do desensitization protocols, they start with rituximab and plasma exchange. At some point, they were using splenectomy, but not anymore. And then they continue with a very strong immunosuppressive medication and plasma exchange as needed. They do something that is called a local infusion, which is to introduce prostaglandin together with steroids into the hepatic circulation, trying to prevent any antibody-mediated rejection. So the outcomes for this transplant, they looked at the antibody-mediated rejection incidence in patients receiving rituximab was only 6% at 1 year, and 23% of patients not receiving rituximab. So they also looked at the antibody-mediated rejection was predicted by the IgG and IgM titers post-transplant. So the patients that have high titers after the transplant were the ones that develop antibody-mediated rejection. So this is a critical point, since we still don't fully understand what is the role of these IgG and IgM antibodies after the transplant. And the overall 1-year survival was 80% for the patients with no antibody-mediated rejection and 40% with patients with antibody-mediated rejection. Again, this shows how critical it would be to remove these antibodies when we try to attempt an ABO incompatible liver. So what is the UW experience? Well, in the last 5 years, we have performed 2 ABO incompatible transplants. Both of them were fulminant liver failure. So these were patients with very high MEL score that if they hadn't received an organ would have died within hours. So that was how desperate the situation was. So one of the patients is a 19-year-old male. He was group O, so he has anti-A, and he received a donor A. Before the transplant, the titers were 64 and 128. So the patient received apheresis before and after the transplant. The IgG and IgM levels persisted elevated after the transplant. Initially, they decreased, and then after the transplant, after the first week, the titers started increasing, didn't respond to plasma exchange, and he was retransplanted with an ABO-compatible transplant 2 months later. So the graft survival on this patient was 2 months, but the patient is still alive 2 years later. So this was also a successful story, even if we consider that ABO-incompatible liver was bridged to the compatible liver. The second patient is the 56-year-old female that was also group O and received a donor AB. So this was as incompatible as it can get. So the IgG and IgM levels were not that high in the 64 range before the transplant. We performed apheresis before and after the transplant. The titers remained low, and then even 1 year after the transplant, without apheresis, of course, the titers continued to be low in the 2 and 8 range. So the graft survival and the patient survival is greater than 1 year. So this patient didn't need a second transplant. So this was a completely successful story for the UW experience. So what is the ASFA guidelines says about the ABO incompatible transplant? Well, for kidneys, as you can imagine, the desensitization, as I mentioned, how they correlate very well with the ABO compatible, the desensitization is a category type 1. That means that you can do it because it's actually helpful and it helps to reduce the antibody. For antibody-mediated rejection, well, it helps as well. Group A2 to A2B or IntoB disease donor. So when we do the group A2, we know that we don't need to do apheresis on these patients when we transplant low titers B. So it's a category type 4. That means we shouldn't desensitize these patients. These patients don't need apheresis. When we look at the livers, the desensitization for living donor, as based on the Japanese experience, is a category type 1. That means it helps, it works, so you should use it. For deceased donor, it's a category type 3. That means we don't know. And again, there is not, the strength of the evidence is 2C. That means there is a weak recommendation. That means we don't know exactly. There is not a whole of data to show you or to tell you if you should do it or not. The antibody-mediated rejection, again, is very difficult to prove, and there is not a lot of evidence. For the group A2 into A2Bs or into B from deceased donor, that we have the 358 patients from the National Registry and the 14 patients for the University of Washington, hasn't been addressed by the American Society for Apheresis. I'm not sure in the next guidelines if this is going to be addressed, but it would be good to have some comments on this one. So what is next? So after the last ABO incompatible liver here at the University of Washington, there was a multidisciplinary team that actually created a desensitization protocol to help these patients that are in fulminant liver failure to get an ABO incompatible transplant. So we do have a protocol here, but we haven't enrolled any patients so far. We do need better understanding of ABO, about the ABO expression in the endothelium. Again, we know that maybe the kidneys and the livers, the ABO expression is different based on the organ. We do need to have better understanding of the critical ABO antibody titers before and after transplant. So we know that for kidneys, when we are doing an A2 into a B, we do have to have very low titers. For livers, it seems that it doesn't matter. So again, we do have to have better knowledge of that. And also, we don't know if accommodation that has been also very well established in kidneys, if something similar happens into livers, we just don't know. So to get evidence, how can we get evidence from these patients to support better these patients? So one way is to create a registry. This is a rare occurrence, so there are not many opportunities to encounter these patients or to collaborate with other institutions. And this is how I would like to start talking about the other project, which is a successful project that collaborating with other institutions help us to give some answers to a very rare disease. So the other rare disease that I'm going to talk about is about hyperleukocytosis. It's not an entity itself, but actually a manifestation of patients that may have acute hematological malignancies with very high white blood cell count. So hyperleukocytosis usually happens when, or can provoke something that is called leukostasis. And leukostasis represents signs and symptoms when the patient has white blood cell count greater than 100,000. So again, these are patients with a new onset of a hematological malignancies, have a very high white blood cell count, and now because of this very high white blood cell count, they may have neurologic symptoms and pulmonary symptoms, and these patients are very sick. So the number one goal on these patients is to reduce the amount of white blood cell count that they have in circulation. So the number one thing that we can do is to start chemotherapy, and the other thing that we can do is we can do apheresis on these patients to remove the white blood cell count. So when we do this treatment, for the most part, we modify this treatment a little bit to improve the collection of white blood cells. And what we use is something that is called hydroxyethyl starch. So hydroxyethyl starch, it is a starch that actually helps sedimentation of red blood cells, separating the red blood cells from the white blood cells in the interface, so the machine can actually collect the white blood cell count without taking the red blood cells. So it improves the collection. It's not widely used, but many institutions use them. So it's been shown in the last 10 years, 15 years, that this hydroxyethyl starch has multiple adverse events. This starch has volume expanding properties, so usually it has been used in the past as a volume expander, mainly for patients with sepsis or shock or hypotension. So when we use the hydroxyl starch during sepsis or during cardiac surgery, it's been shown that these patients actually have high risk of renal disease and also death. So that's not very good. So the FDA used a black box warning saying you shouldn't be using this unless it's really, really needed. And in Europe, hydroxyethyl starch is not longer approved for use. So this happened about 2 or 3 years ago in 2012, and the apheresis community was very concerned about this drug because, again, many hospitals use this drug and say, can we still use it? Should we stop using it? We think we benefit our patient when we use it, but we don't know. So for the most part, the amount of procedures that one institution can perform is about between 5 and 10 procedures. So acute leukemias with hyperleukocytosis are very rare. It's a rare entity. So it was a challenge to try to answer this question. So what we did was, there is the ASFA, the American Society for Apheresis, have a research subcommittee. So we came together and said, how can we answer these questions all together? So the proposal was to evaluate the renal toxicity in patients undergoing leukocytopheresis using the starch. We put together a research plan looking at outcome variables, including the creatinine levels within the first 24 hours after the procedure, and secondary outcomes looking at the need for renal replacement therapy, adverse events rate, and the white blood cell count after the procedure. We elected to do a retrospective chart review, and we look at a 5-year period. And 6 institutions participated in this study. So we used the REDCap database to collect the data. Every institution looked for IRB approval and data use agreement. And we did a statistical analysis looking at something that is called difference in difference regression analysis. So I need to disclose this, that the REDCap study data were collected and managed using the REDCap. And the REDCap is a secure web-based application designed to support data capture for research studies. And these were the results. So we were able, between the 6 institutions, to recruit 195 patients. Most of the patients did not receive starch, and just a minority received starch. As expected, most of the patients had acute leukemia, and most of the acute leukemia or myeloid leukemia were M4, M5. And this was expected because these patients usually have very, very high white blood cell count, and they do present with leukostasis, with signs and symptoms for leukostasis. When we compare at the baseline characteristic of the 2 groups, they were very similar in terms of the white blood cell count and renal function. So we look at the procedure characteristics, and there were no big difference between the 2 groups. And when we look at the primary and secondary outcomes, we look at the creatinine actually was not different when we compared before the procedure and after the procedure within 24 hours, and before the procedure and 7 days after the procedure. What we did find was that when we look at the white blood cell count reduction from day 0 to day 1, is that the patients that received starch actually had a benefit because they reduced the white blood cell count by 25% more than the patients that did not receive starch. Again, this is very consistent with the current data that we know that starch can improve the white blood cell count. There were no differences in the creatinine, the glomerular filtration rate, and the white blood cell count after 7 days in the 2 groups. And the other thing is that when we look at actually how the patients recover clinically, we use something that is called the Novotny score, which is a severity score used for patients with hematological malignancies. And basically, we look at the respiratory status and the neurologic score. So the score goes from 0 to 3, 0 means asymptomatic, and 3 meaning severe symptoms. So this is the grade, and these are the patients. So there were some differences in the baseline characteristics on these patients. In the HES group, there were more asymptomatic patients than in the no-HES group, that there were not that many asymptomatic patients. And then in the no-HES group, there were many patients that have very severe symptoms. So the conclusion from this study was that the use of the hydroxyethyl starch did not result in increase in renal toxicity. The use of hydroxyethyl starch resulted in higher cytoreduction. And also the respiratory symptoms improvement was superior in the group that received starch. Of course, there are several limitations on this study, which is the retrospective nature, the variability between institutions, and this group was a heterogeneous group of patients. The advantage is that the use of a registry facilitated obtaining enough patients to develop a meaningful study. So what are the challenges and opportunities? Well, I think with these two presentations, it's very clear what are the challenges that we have when we are deciding whether apheresis is useful or not to treat our patients. The number one is that the challenges for doing research is that there is lack of support for apheresis research. There is low incidence of some of these diseases. These procedures are costly. There is a limited number of centers with, for instance, extracorporeal photopheresis or LDL apheresis. There is limited animal models for apheresis, and there is lack of infrastructure for apheresis research. So in 2012, there was a meeting at the NIH that is called the State of the Science Symposium in Therapeutic Apheresis, in which several professionals from the apheresis community got together and discussed what are the proposals or the recommendations to try to improve the apheresis data. So the recommendations were to establish a consortium for apheresis medicine to facilitate networking, information exchange, and research collaboration. To specifically charge in existing studies section, there is not a specific studies section at this time for apheresis research. So the idea would be just to add apheresis in one existing study session or develop specific funding to include apheresis medicine. And also to promote apheresis medicine as a viable field for research for junior and established investigators. So the American Society of Apheresis, what it's doing is, well, they do have a research subcommittee that includes multiple institutions, and they are developing registries for rare diseases. At this time, they only have 4 diseases, including Wilson disease, myasthenia gravis, neuromyelitis optica, and leukocytosis. That is a study that I just presented. But in the future, they would like to include sickle cell disease, TTP, LDL apheresis, ABO incompatible liver transplant, and I forgot to include FSGS as well. So talking about registries, there is not a national registry for apheresis in the United States. There are registries in Canada, France, the International Society for Apheresis that includes many European countries, and the World Apheresis Association. So annually they present a report, but they are very conscious that this actually is not representative for all the apheresis procedures they have, so it's still limited. And why I'm doing all this emphasis on the registries? Well, there is this idea of doing this randomized registry trial, which is, the concept is using big data with small money. So this was a study performed in Scandinavia in 2012, I believe, 2013. So what they did was, with little money, they created this very high quality observational registry. So they were including all these patients as in a regular registry. And then as they were including patients, they were able to identify patients that may qualify for a randomized trial. And then they randomized these patients in real time. And it was very cost effective, to the point that they enrolled more than 10,000 patients in 2 years with $300,000, so $50 per patient. That's quite impressive. Of course, it's Scandinavia, and the system is a little bit different from our system, but I think that's something that we may start considering when we have a low incidence disease as well. So with this, I would like to finish. So Theodore Roosevelt, which was a president from the United States in the beginning of the 1900s, said, "You do what you can with what you have where you are." I remember my grandmother saying this as well in several opportunities. I think the idea is just to try to be creative and use the resources that we have. And I think in apheresis we can take a lot from this. And I would like to acknowledge the ASFA Research Subcommittee and the participating institution. Without them, I wouldn't have been able to perform the study. I also would like to thank the transplant service at the University of Washington Medical Center, in particular Dr. Lina Cibulewski, who helped me to put the data together for the liver transplant here, the Transfusion Support Laboratory, and of course the Bloodworks Northwest Apheresis Service physicians and nurses who take care of all these patients, and they are a great group of people. With that, any questions?
So as you're thinking of registry, I'm a nephrologist and we did a lot of pheresis for some of the neuro patients, but you get this high concentration with your first pass of potential antibodies that could be useful for research. Have you ever thought about having some, banking some of these that might be useful for research projects?
So yes, the question is from a nephrologist. If when they perform all these apheresis procedures and the concentration of antibodies higher in the beginning of the procedure, because there is no dilution, if we can use this as a repository, if we can take these samples as a repository, I think that's an excellent idea. I think that's what we need to look at. I think apheresis needs more basic research. Observational studies is the first thing that we do to observe, question, and then try to answer. So I think that's the way to go. It would be a good idea, yes. Mm-hmm.
Monica, for transplanting A and B positive organs into other patients, does secretor status matter?
So the question is, when we are doing A or B organs into a patient, does secretor matters? Yes, I've been thinking about it. I think that's another thing that we need to look at. The only thing is that when we have an O recipient has anti-A and anti-B, so there is no soluble A or B at that point that could help us to decrease the antibodies. So the A organ comes, and I don't know if the secretor status will help as much or not. Probably it does. So just to translate to the non-blood bank community, what is a secretor status? So as I mentioned before, we do have ABO on our red blood cells. And for the most part, most of the patients would have also ABO in our endothelium and other places and secretions. But if you are a non-secretor, that means it's on your genes that you are called non-secretor, you are not going to have ABO expression in your secretions, basically. So those organs would be protected against the anti-A or anti-B. That's something also to look at, yes. Mm-hmm.
Could I ask you about accommodation?
Yes.
And the mechanism of epitope spreading, and could you tell us a little bit how it works, and then is there data that you can gather from the patients to determine if it has happened, is happening, or will happen?
So the question is about accommodation and epitope spreading, and if we can show whether it has happened or it hasn't happened. The answer to that is I don't know enough to tell you exactly how it happens or how we can demonstrate that. So what we know is that when we have biopsies of these patients, you would have, so a patient that has accommodated, right? So you take a biopsy from the kidney, you would have in the endothelium the antibodies and complement. And you will see that. You will see that deposition, but you don't see the damage that antibody and complement would produce when they become activated. So, that's the principle of accommodation. Like you do have complement binding, you do have antibody-antigen reaction, but what you don't have is the damage.
And then when you use HES, you talked a lot about you get excellent reduction of leukocytes. And in some patients that they have sepsis-like symptoms, and so you can have sepsis-like symptoms in the absence of bacteremia. And so are these patients getting sepsis-like symptoms in the absence of bacteremia? And if that's the case, is it possible that the leukocytes during the process are actually becoming activated and spilling into the material you're providing back to the patient, and so plasmapheresis is something that needs to be done in addition to that. And the basis for asking that question, right, is a number of genetic syndromes that lead to phagocytic cells that are susceptible to creating autoinflammatory syndromes.
All right, well, that's a very complex question because you touched on the hydroxyethyl starch to be used to reduce the amount of white blood cells. Also on septic patients, and apheresis has been tried on sepsis regardless the white blood cell count and regardless the hydroxyethyl starch. So what is your question again? Sorry.
So I thought I understood that some of the patients that were where HES was being used, but they displayed sepsis-like symptoms.
Right. So actually, patients with sepsis that were in multi-organ failure and hypotensive and they needed volume expansion, they were using HES as a volume expander without apheresis, without anything else. Right. So they would use it as a volume expander. I think there is all this controversy between giving crystalloids or colloids, right? Okay, part of those colloids would be the HES. So how do we better expand these patients that are volume depleted? So in that context is when HES was used. And in that context is when it was shown that the patient had renal toxicity and increase of death. Yes?
You talked about an observational study using HES, and I wondered if you can think of any reason why a randomized study using HES might give a different result.
I was so concerned about your questions because Amelie is a statistician. So what if we do, so the question is, we did an observational study and what would happen if we use a randomized control trial for this population? I think the main concern about doing the randomized control trial is, number one, these patients come through the emergency department very sick. So I don't know if it would be possible to consent these patients saying, hey, do you want starch or non-starch, when actually they may die within the next 12 hours. So it is a very acute disease. Number two, there are not enough patients. So 6 institutions, 5 years, 200 patients. That's not a very big number. And if we take into account that many patients will not consent, so probably we would get with 50% of consent, let's say 50% consent, we would have taken 2 years or 5 years to get 100 patients. And I don't know if we would have been able to see a difference. I think that those were the challenges of a randomized control trial.
So one thing you could do rather than do that is just make sure that your participants were otherwise comparable, and I think that's what you were.
Right. So the statistician, the person that did the statistical analysis, actually did this propensity score match. So we were right. So we were sure that actually the two were actually comparable. So we can